Hi everyone, my name is Dr. Shintaro Akiyama. I'm a gastroenterologist at the Department of Gastroenterology, University of Tsukuba. On behalf of my co-authors, I'm glad to tell you about our recent work on clinical usefulness of hypoxia imaging colonoscopy for the objective measurement of ulcerative colitis disease activity, which was recently published in Gastrointestinal Endoscopy. We'd like to thank GIE for giving us the opportunity of this interview. Ulcerative colitis (UC) is a chronic intestinal inflammatory disease of unknown etiology. Management of UC requires therapeutic targeting, defined as objective improvement of active inflammation within the colon. Although the various tools have been developed to monitor disease activity, inter- and intra-observer bias cannot be ignored. Bowel urgency is the most frequent and disruptive symptom that impacts quality of life and clinical outcomes in UC patients. Because the mechanism of bowel urgency is multifactorial and associated with decreased rectal compliance and hypersensitivity due to chronic inflammation in the rectum, a reliable objective measure is still lacking. Chronic mucosal hypoxia is associated with mucosal inflammation in UC. The main mechanisms of mucosal hypoxia include high oxygen demand by inflammatory cells and microvascular dysfunction. Previous studies using endoscopic probes revealed a negative correlation between tissue oxygen saturation, StO2, and disease severity in UC. While endoscopic probes need to be attached to the colonic mucosa for measuring StO2, hypoxia imaging colonoscopy can provide real-time StO2 mapping along with white light endoscopic images by simply changing the image mode. These are the images of the hypoxia imaging colonoscopy. A left image shows white light image. A right image is StO2 image obtained by hypoxia imaging colonoscopy. In the StO2 images, redder and bluer colors represent values closer to 100% and 0% of StO2, respectively. StO2 values of this region of interest was 56%. We presumed that hypoxia imaging colonoscopy enables easy and objective disease monitoring of UC. For instance, hypoxia imaging colonoscopy is expected to provide homogeneous results between experts and non-experts. So we aim to evaluate the clinical usefulness of hypoxia imaging colonoscopy for the objective assessment of disease activities of UC. In our IBD center, Simple Clinical Colitis Activity Index (SCCAI) was routinely assessed at the date of colonoscopy or clinical visits. SCCAI was selected because this score includes bowel urgency subscore. Clinically active disease was defined as SCCI of 3 or more than 3. Endoscopic active disease was defined as Mayo Endoscopic Subscore (MES) of 2 or more than 2, or ulcerative colitis endoscopic index of severity (UCEIS) of 2 or more than 2. Histologic activity was defined as the Gabos score of 3 or more than 3. In this study, white light image along with StO2 image were taken regularly, just prior to biopsy. Biopsies were performed from the site most likely to reflect the degree of inflammation. To confirm the hemostasis and to record the location of the biopsy sites, images were also taken just after biopsy, or when the colonic mucosa was grasped with forceps biopsy, like this image. Next, investigators at Fujifilm individually assessed endoscopic still images to determine colonic StO2. A square region of interest centered on a point corresponding to the subsequent biopsy site was set and STO2 was calculated. We assessed 102 consecutive patients with UC. Median age at colonoscopy was 37 years. Extensive colitis was predominant. Median maximum values of MES and UCIS were 1 and 2, respectively. The median SCCI was 1. A majority of the patients were receiving oral mesalamine or sulfasalazine at the time of colonoscopy. 25 of patients received thioprins. 14% of patients received systemic prednisone. Among advanced therapies, the most common medication was vedolizumab. Representative image of hypoxia imaging colonoscopy in a patient with UC. White light and STO2 images are shown in the right-sided column, transverse column, sigmoid column, and the rectum. As you can see, the right-sided column and the transverse column with endoscopic and histologic remission had a STO2 of more than 50%. On the other hand, the sigmoid column and the rectum with endoscopically histologically active disease had a STO2 of less than 40%. We assessed correlations between clinical symptoms and STO2 at each anatomical location of the colon. This analysis identified a significant correlation between rectal STO2 and SCCAI. The correlations between SCCAI and STO2 at other anatomical locations of the colon were not significant. Next, we examined correlations between rectal STO2 and each subscore of SCCAI and showed the strongest correlation between rectal STO2 and urgency of defecation. We assessed 490 images and STO2 was compared between groups with different disease activity, endoscopic and histologic scores. As a result, patients with higher endoscopic and histologic UC activities demonstrated lower colonic STO2 with significant differences. When the cutoff value of rectal STO2 was 40%, rectal STO2 had moderate accuracy to predict clinical active disease and bowel urgency. When the cutoff value of colonic STO2 was 45%, colonic STO2 had moderate accuracy to predict endoscopically and histologically active disease. This study showed colonic STO2 obtained by hypoxia imaging colonoscopy was significantly correlated with UC disease activities. We have three key messages. Rectal STO2 may be a novel objective measure of bowel urgency in UC. Hypoxia imaging colonoscopy facilitates easier objective endoscopic monitoring for patients with UC. Colonic STO2 can be a therapeutic target for UC. In conclusion, we discovered STO2 obtained by hypoxia imaging colonoscopy is useful for assessment of clinical, endoscopic, and histologic activities of UC. Thank you for your time. Please let us know if you have any questions.